So our next speaker is Dr. Anna McGuire. She's a thoracic surgeon at the Vancouver General Hospital, University of British Columbia, a great friend to the meeting and of mine, and has been coming here for the last few years. She's going to talk to us about a whimsical title, To Be or Not to Be, that is, or To Be or Not to TNMB.
Oh, this is actually not my first slide.
Oh, can we go to Dr. McGuire's first slide, or maybe you can dial it back?
Okay, there it is.
All yours.
It just basically says my name. Okay, well, good morning, everybody. Thank you so much for the opportunity to speak. Today we'll explore, I just have to adjust these because I'm pretty short. We're gonna speak about an emerging paradigm in lung cancer staging, liquid biopsy, and whether it's ready or not to supplement existing methods. Okay, to be or not to be. This is the opening phrase from the soliloquy from the nunnery scene from William Shakespeare's Hamlet from about 1603. And in this speech, a despondent Prince Hamlet contemplates death and suicide. He bemoans the pains and unfairness of life, but acknowledges that the alternative still might be worse. Now, I don't know about you, but I was first introduced to Hamlet as a teenager in the Vancouver Public School Board English class. And despite English allegedly being my first language, I had no clue what was going on. Neither did my colleagues, and none of us could navigate it. We couldn't understand Old English. Frankly, this is how I feel a lot of the time when trying to understand the different ctDNA and liquid biopsy assays and analytes. It might as well be old Shakespearean English. So, how do you get by? Well, how did we get by? In high school, the Coles notes, of course, thanks to the brothers Jack and Carl Cole, who first published these just after World War II, actually, in 1948. And then they sold the rights to Cliff Helgas, who then published it under the Cliff Notes. So you may be familiar with Cliff or Cole's notes. I don't know if this shows my age. I don't know if this is even still used, but this is how we got through. And analogous to this, I hope to give a general overview of some things that many of these people in the room are clearly already aware of and more expert than I in this topic about how it could be applied, the plot, the characters, the themes to a comprehension of TNMB. The important disclaimer that I have is that I'm a thoracic surgeon, and so I see the world through a biologic and anatomic lens. I am not a molecular pathologist. Why re-examine staging in non-small cell lung cancer? Because it's our plot. It guides everything. It remains the foundation of treatment decisions, and cancer management relies on staging at initial diagnosis. The stage at which cancer is diagnosed is one of the, if not the most important predictor of survival. As we just heard from Dr. Joubert, conventional staging of malignant tumors follows the TNM notation, encompassing tumor, nodal metastases, and detectable distant metastases. However, this traditional TNM staging has difficulty achieving accuracy in prognosis stratification at the individual patient level in certain specific circumstances. This has become clearly evident in our current era of lung cancer screening, early detection with low-dose CT scans, as well as with the advent of highly active systemic therapies, including targeted therapy and immune therapy. And this is the theme to take away from my brief review, is what is the potential clinical utility for staging of liquid biopsy and ctDNA versus the reality, especially for early stage non-small cell lung cancer. So this slide depicts a summary of the standard workup for patients with non-small cell lung cancer being considered for surgical resection. We know that it includes clinical staging, TNM, physiologic assessment, but what has emerged is a new standard for early stage non-small cell lung cancer as well as late is a biomarker assessment. And in this evolving clinical landscape, there's recognition that even early stage non-small cell lung cancer should be assessed as a systemic disease entity. Because as we adopt the precision therapies, we need also to more precisely and in a minimally invasive manner stage It's become ever more pressing. No, it's not advancing. It's not going back either. Oops, now it's going back. Okay, apologies. So with the growing power of genomic profiling, some have proposed adding a fourth dimension to the staging system, B for blood or biomarker, based on liquid biopsy for circulating tumor DNA in the blood. The attractiveness of a TNMB model integrates molecular data into the staging system, potentially bringing us closer to true precision medicine and ultimately better outcomes for our patients. Because as we know, all too often, the responses are short-lived to targeted therapy. A major limitation for precision cancer staging is the inherently heterogeneous and fundamentally dynamic systemic nature of cancer. And by improving this disease characterization, both initially and over cancer progression, we can more precisely apply treatment. So liquid biopsy, many already are well aware that liquid biopsy is an umbrella term. It refers to several different analytes that are measurable in whole blood and in plasma. Each provide different biologic insight. And from a clinical point of view, plasma circulating tumor DNA is the most extensively studied and widely adopted alternative to tumor tissue genotyping for solid tissues, including non-small cell lung cancer. And this image shows mechanisms of cell-free DNA release from body cells. The fraction of cell-free DNA in the blood that arises from the tumor itself is known as the circulating tumor DNA, or ctDNA. And from these fragments, we can detect tumor genomic alterations. And just as a brief review, healthy people rarely have more than 10 nanograms of cell-free DNA per mil of blood in their plasma. And most of this originates from hematopoietic cells. And physiologic stress events of basic living have been shown to influence its release from non-cancer host cells, including intense exercise, autoimmune disease, stroke, heart attack, trauma, and infection. And so the fragmented tumor-specific DNA can be shed into blood passively via apoptosis and necrosis, or actively via the secretion of the microvesicle exomes. ctDNA levels in blood are generally low, and they've been shown to be directly proportional to tumor burden and clinical stage in non-small cell lung cancer. Going forward with cell-free DNA has a short half-life in the circulation of whole blood. It has a range that's been reported to as low as 16 minutes to clear versus up to 150 minutes. As such, it's been very attractive to potentially use it based on ctDNA as a real-time measure of tumor burden. The clinical challenge, the reality is that ctDNA comprises less than 1% of total cell-free DNA in a typical patient. And as I mentioned, ctDNA analysis has numerous potential applications that are summarized in this slide, ranging from screening and early detection, assessing risk of relapse, prognosticating, deciding on targeted therapies, assessing clonality over time for tumor progression, and then after surgery, potentially deciding who should get more therapy or strategic decision-making. However, in Canada, Europe, and the United States, ctDNA liquid biopsies are currently only limited to a few uses outside of clinical trials. Where they have shown value is to guide treatment decisions in advanced stage 4 non-small cell lung cancer. And the other potential applications, especially in resectable early stage non-small cell lung cancer, remains experimental, although it's under evaluation globally. So these are the NCCN most recently available guidelines. And you can see that my previous slide summarized the high hopes for ctDNA, but the reality in guidelines right now is that there are challenges to overcome with liquid biopsy. There's 3 main challenges. And as I mentioned, based on describing the proportion, A huge problem is the limited detection sensitivity of tumor-related biomarkers that you can find in peripheral blood and plasma, especially in early-stage lung cancer. Even among patients who have a known EGFR tumor tissue mutation, for example, there can be up to a 30% false negative rate reported with ctDNA, even in advanced cancer. Secondly, clonal hematopoietic mutations of undetermined origin. These are positively correlated with advancing age, but they are not directly correlated with tumor development or tumor burden. And it's essential to account for these hematopoietic changes when variant calling in ctDNA for tumor variants. And lastly, the third major problem is that there is a lack of standardization in the use and methods of liquid biopsy for clinical application. Currently, there's no universally accepted standard to fulfill all of these clinical requirements for selection, sample processing, and detection method criteria and variant calling. And what is happening now is that in various studies, the detection is being tailored according to specific scenarios. So for example, in the screening scenario, greater emphasis is placed on tests that are high in sensitivity for early detection. However, in the postoperative molecular residual disease situation, testing is more focused on enhancing specificity of the assays. So here's another busy slide for a busy topic. And as mentioned, ctDNA is the most extensively studied liquid biopsy approach, even though there are others. And although, as I mentioned, one of the major limitations is detection-related sensitivity, especially for early-stage tumors, multiple studies from different populations globally have demonstrated feasibility. That being said, of the studies listed here, a direct comparison of test performance characteristics of sensitivity and specificity of different assays designed to detect MRD or molecular residual disease is highly challenging because of the differences in the cohorts and processing methods of the liquid biopsy itself. And with respect to the different technologies studied for the purpose of ctDNA blood analysis, I've summarized the big four here. Generally speaking, these technologies for ctDNA detection in blood can broadly be classified as tumor tissue naive or, tumor tissue informed or tumor agnostic naive. And each has their advantages and disadvantages. So just briefly, the tumor naive has the advantage that you don't have to have tumor tissue, however, you trade off sensitivity for this benefit. Tumor-informed approaches have the benefit of higher precision, but also higher cost. And genome-wide approaches have the value for ctDNA is that you can potentially overcome this low input problem. And lastly, epigenetic approaches of methylation are very valuable, especially for increasing sensitivity and specificity, where methylation is an epigenetic feature where the patterns of expression can be used. So with respect to the clinical utility of the role of ctDNA as a prognostic biomarker, we can lean on the recently published Checkmate 816 5-year overall survival data, hot off the press from the beginning of June in the New England Journal of Medicine. And as we know, ctDNA clearance, it has been previously used to identify patients who've had cancer resected who are at risk of relapse. But this slide is valuable because it showed that ctDNA clearance was also demonstrated to be prognostic of overall survival in this paper. Okay, bringing it all together, depicted here in these pictures is a theoretical framework put forward by Chen and colleagues for a new tumor nodes metastasis and blood biomarker staging system proposing integration of ctDNA assessment into the TNMB system. And in this system, you can be classified as B0 or B1, where B1 corresponds to ctDNA positivity and B0 indicates ctDNA negativity. In all patients, regardless of TNM 1 to 3 staging classification, if they are ctDNA positive, would be classified as TNMB 3. So my 5 cents, not 2 cents, because in Canada we don't use pennies, we round up for prosperity of all. So to be or not to TNMB? Well, in my opinion, not yet. However, I believe the future of staging is molecular, and it will be soon. And our job is to shape this responsibly. I believe we need to continue robust clinical trials that include blood biomarker biospecimens that validate liquid biopsy as a staging tool specifically, not just for recurrence or treatment monitoring. And these trials are underway, but then we'll have to deal with the path to regulatory approval and clinical consensus to achieve standardization for the different uses, to ensure reproducibility and validity. This remains complex, but I believe it's feasible. So thank you very much for your time and attention.